Good evening. My name is Luella Meacham, and my project is Attitudes and Self-Perceptions of Mental Illness and DEI Among Mental Health Professionals. My project chair is Dr. Brandy Fewen. My second reader and mentor is Dr. Alfredo Adu. The tidal wave. Instead of the nurse having their concept of the patient with a mental health diagnosis, the nurse allows the patient to voice their own identity. Walker and Buchanan Baker. Definitions. Implicit bias is having beliefs and prejudged attitudes without being consciously aware. Diversity is groups in the community or population, including ethnicity, religion, abilities, sexual orientation, and other dimensions of diversity. Inclusion is the engagement of all groups mentioned. Accessibility and accommodation creates inclusive environments for individuals with unique needs. 60% of those diagnosed with mental illnesses will not seek treatment, will not seek medical help for fear of being labeled. Health professionals' stereotyping further compromises care. It is essential to assess such attitudes to understand the stigma and, if needed, develop a test appropriate and culturally adaptive interventions to reduce it. The Community Mental Health Act of 1963 ushered in an era of hope, which developed the new recovery models. Recovery is a goal or desired outcome of treatment. Mental health treatments shift from the hospital to the community. Recovery is not a cure, but determined by the individual and a way to have a meaningful and satisfying life. Recovery-oriented support programs are peer-run, where self-empowerment is practiced. Stigma is defined as a mark of shame and disgrace or disapproval for individuals living with mental illness. Discrimination is the result from stigmatizing attitudes, and human rights are violated. Stigma can act as a barrier to opportunities, especially in accessing necessary mental health services. Anti-stigma campaigns promote attitudes of inclusion for those with mental health disorders. The DMP can develop policies that address nursing attitudes about mental health disorders. They can promote education and training about implicit bias, self-examination, and being culturally competent. Nurses can use the outcome measures from this study to develop guidelines for educating nurses. This education should start at the undergraduate level. Also, it is recommended to educate the public about mental health disorders and social determinants of health to be incorporated into patient assessments and treatment plans. According to literature, the stigma is damaging to those with mental illness, causing poor compliance with treatment. Stigma manifested at several levels as public stigma affecting cognitive and behavioral reactions, and self-stigma causing fear of being exposed to negative beliefs and feelings. What's missing in nursing studies? The need to uncover the underlying issues related to stigma and mental health disorders, examining the attitudes of mental health professionals, and setting up the framework for future projects. Also, provide the material to develop guidelines to address problems identified and bring outcomes to practice. Studies show there is a lack of education for nursing, and nursing leaders should support and offer educational guidelines for new nurses and student nurses about mental illness. The DNP can educate individuals on how to deal with feelings of stigmatization. Qualitatively, nurse leaders can examine how both the individual and the nurses experience to understand stigma and its effects. Qualitatively, nurse leadership can examine how both the individual and the nurse experience stigma, to understand stigma and its effects, using the information to form their approach and interventions when caring for those with mental illness. The purpose of this project is to evaluate the attitudes and self-perceptions of mental health professionals regarding mental illness and DEI. Evaluating these attitudes using the Community Attitudes Towards Mental Illness, the CAMI tool, perform thematic analysis of two open-ended questions regarding stigma and DEI, sharing the outcomes via publications and podium presentations. The goal is to promote attitudes of inclusion regarding people with mental and substance use disorders, especially among mental health professionals. The clinical practice question: in individuals working in mental health settings, what are the attitudes and self-perceptions of mental illness and diversity, equity, and inclusion? There were 6 themes obtained from the review of literature. Examining the cause of stigmatizing attitudes, how stigma is measured and defined, interventions are needed to reduce stigmatizing attitudes, professionals with stigmatizing attitudes, effects and care by stigmatizing attitudes, and examine the implicit and implicit bias attitudes. Examining whether the treatment settings contribute to stigmatizing attitudes. Professionals with experience and higher level positions were more positive, but most staff were positive. This was a study examining the differences in stigmatizing attitudes of mental health professionals and other professionals. The mental health professionals showed more positive beliefs regarding stereotype beliefs. However, there were some inconsistencies with some studies reporting similar results and other more negative or positive results in comparison with the general public. Stigma should be defined in the context of social, economic, and political power. Stigma is defined as labeling, stereotypes, social distance, status loss, and discrimination. Examining the language usage of mental health professionals and compare them with non-mental health professionals. Mental health professionals have fewer stigmatizing attitudes. Health professionals promote positive, compassionate, and supportive attitudes towards people with mental illness. However, some health professionals do often convey less supportive perceptions of recovery for people with mental illness. And medical professionals did not have an overall positive attitudes towards individuals with mental disorders. Nurses without frequent contact, collaboration with patients have more stigmatizing behavior. Also, nurse dehumanized by supervisors also dehumanize their patients with psychiatric disorders. Stimulated mental health practices can reduce stigmatizing attitudes. Stigma can affect access to treatment due to mental health professionals are patients' only avenue to treatment. Stigma adverse impact on those with mental disorder. Some professionals do have explicit and implicit attitudes towards those with mental illness. However, personal contact with people with mental illness may reduce stigma. The Canadian Mental Health Association validates stigma is a reality for many people with mental illness. The National Academies of Science report explains there is evidence why stigmatizing attitudes should change. The World Health Organization Action Plan for 2013 to 2030 is to promote mental health and well-being because stigma is damaging to mental health population. The theoretical framework is a title model, which emphasizes the importance of allowing the patient to tell their own story, then accepting and fostering independence instead of dependence. The assumptions are the patient should have control of their own lives, speak their own language, and have their own identities. The Johns Hopkins evidence-based practice model has 3 stages used as a guideline to translate evidence-based practices into clinical practice. The 3 PET stages are P for practice question, for the practice question, and project planning. E is for evaluation, and T is for the translation stage. The Johns Hopkins evidence-based practice and a title model can be utilized in this project because it will help translate the project's outcomes into clinical practice and form a structured process. A mixed method evidence-based practice project, the qualitative design examines 2 open-ended questions, creating themes through thematic analysis. The qualitative approach uses numeric values as demographics, 2 yes or no questions, and a CAMI tool to identify stigmatizing attitudes of mental health professionals. A descriptive mixed method design used a combination of both quantitative, the community attitudes towards mental illness, or CAMI, demographics, and yes and no questions, and the qualitative open-ended questions with themes, data collection via Quadrix and Atlas TI. Individuals working in a mental health setting, what are their attitudes and self-perceptions of mental illness, diversity, equity, and inclusion? The sample size expected was N105. The actual sample size was 32. The setting was the American Psychiatric Nurses Association's discussion forum, posting a recruitment announcement there, composite sample for the APNA nurses, and snowball sampling for professionals working in a psychiatric setting. The inclusion criteria included those over 18 can read and speak English, working full or part-time with those with mental illness, registered and licensed nurses and other mental health professionals. The excluded are those the opposite of the included criteria. Participants consented by reading and consenting to participate. If they checked no, the survey ended. The PI's contact information was listed on the consent, emails, and posting to be contacted with any questions. The risks were explained and information for counseling if needed was also given. The only possible risk was eye strain from taking this test. The demographic survey was the first survey to be completed, asking years of experience, gender, race, highest degree obtained, specialty area of practice, employment status, and type of service provided, and the 2 yes or no questions about stigma and DEI. The CAMI tool was next, examining authoritarianism, benevolence, social restrictiveness, and community ideology. These subscales included 10 items, 5 positive and 5 negative. The score can range from 10 to 50. The original version consists of 40 items, 5-point Likert scale from strongly agree to strongly disagree. 2 separate data collections methods was utilized in Quadrix and utilized APNA for nursing and snowballing sample by emailing the link to professional contacts and ask participants in the email to pass along and forward for more potential participants. The demographic survey and the CAMI use Intellectus statistical software and analyzed using descriptive analysis arranged as frequent distribution from lowest to highest percentages. Atlas TI analyzed the qualitative data by gathering the participants' answers to the open-ended questions and separating them into themes. To evaluate the trustworthiness of the SPP, the project is separated into 5 areas: credibility, dependability, confirmability, transferability, and authenticity. Credibility is confident that the value of the results is accurate, the equivalent of qualitative internal validity. Dependability, data is stable over time, similar to reliability. Confirmability, the objectivity of the data. Transferability, the external validity in which findings from the data can be transferred to other settings or groups. And the authenticity, the extent to which the PI will honestly describe the participants' lives and experiences. So the demographic survey, the most frequent observed category of race was white Caucasian at 72%, age from 55 to 64 years of age, 31%. Gender was female, woman at 87%. Practice state was Virginia at 50%. Employment status was 69%, and years of experience in healthcare was more than 20 years at 72%. The highest degree was a master's degree at 47%. Professional title was advanced practice nurse at 44%. The most observed type of service was both community care and inpatient services at 30% each. The most frequently observed category of question 1, have you experienced coworkers or peers who talk down or use derogatory language when talking about those with mental health disorders, was yes at 81%. And number 2, do you understand how diversity, equity, and inclusion, DEI, relate to mental health disorders? And the answer was yes at 100%. Here are the definitions for the subscale, the CAMI. Authoritarianism, belief that people with mental illness should be controlled and managed by authority figures. Benevolence, paternalistic and sympathetic views of individuals with mental illness. Social restrictiveness, belief that individuals with mental illness are dangerous and should be excluded from society. And community mental health ideology reflects the acceptance of mental health services and individuals with mental illness in the community. The CAMI questionnaire assesses public attitudes about persons with mental illness. It's 40 items, each rated a 5-point Likert scale for each scale. The most frequently observed category for authoritarianism was 18. The most frequently observed category for benevolence was 43. For community mental health was 41. And for social restrictiveness was 18. And the total score was 120 or 121. The most frequently observed for authoritarianism was 18 with a score range from 10 to 20. With the score range of 10 from 10 to 50, a score of 18 was lower score showing less stigmatizing attitudes. The most frequently observed of benevolence was 43, with the score range from 10 to 50. 43 is the highest score showing less stigmatizing attitudes. Community mental health ideology at 41, and this was 42 is a 42 is a higher score showing less stigmatizing attitudes. And social restrictiveness was 18. Again, 18 is a lower score showing less stigmatizing attitudes. And for total score of 120 is lower score. And so the score of 121 is more favorable towards mental illness. So let me go back and just say that the highest scores on authoritarianism and social restrictiveness scales indicate greater scores, greater stigma, but both of those scores were low, so it was less. And benevolence and community health ideology scales indicate less stigma. And the higher CAMI score suggests more positive attitudes towards individuals with mental illness. A low score indicates more negative or stigmatizing attitudes. So the score shows there were less stigmatizing attitudes in both subscales. So for question 1, why stigma is attached to mental health disorders? The themes collected from these questions were negative stereotypes and insufficient education and comprehension. Explaining negative stereotypes and historical attitudes cause stigmatizing attitudes towards mental illness. So some of the themes in the quotes for individual portrayal of mental illness in movies have contributed to greatly to how we view mental illness. Professional views, people are afraid of unknown. If people struggle with mental health disorders or exhibiting symptoms, they may not be understood and therefore should seen as abnormal. Movies and television have sensationalized and dramatized mental illness, which creates fear. In societal views, much negativity in news and reporting, there's not enough education for the general public. Too many people, too many old movies with stigma. The most Explain why stigma is attached to mental health disorders. Healthcare. I feel that stigma is attached to mental health disorders because people have not been properly educated on mental health disorders. People do not understand mental health, and because of this, they either fear it or ridicule it. societal or public lack of understanding of media portrayal of mental illness in individual. There's a lack of knowledge about etiology of mental illness, and many see it as weakness or willful behavior. Okay, question 2. Explain how DEI creates access to treatment for those with mental health disorders. The themes from this one was barriers to treatment and having access to help. Also stating why biased attitudes are barriers to treatment. DEI allows those with mental health disorders to have human rights and have access to treatment. So some of the themes to that: available access and seeking treatment. It helps mental health clients access care. Addressing biased attitudes and societal and systemic bias, DEI ensures that everyone can access treatment and puts into place that people deserve treatment despite of circumstances. Okay, also some themes to question 2 were normalization and equality. DEI principles are crucial for improving access to mental health treatment by addressing systemic barriers, promoting inclusive environments, and fostering culturally competent care, raising awareness of differences and how there are different needs that should be addressed from an equity perspective so everyone can thrive. So the demographic showed the participants were employed, middle age, white females with experience living in Virginia. Mostly experienced APNs with 20 years or more of experience and a master's degree. The data analysis did not confirm the clinical practice statement. The CAMI score showed less stigmatizing attitudes among mental health professionals. However, the thematic outcomes supported the data about negative attitudes and stereotypes in society towards those with mental illness. These attitudes are displayed in media, movies, and social media. The themes also support the need for educating the community about mental illness. The findings support the literature finding some stigmatizing attitudes, but mostly positive attitudes for nursing and other mental health professionals. Experience and even stimulations help nurses experience and understand mental illness. The findings show a lack of consistency and clarity in about stigmatizing attitudes. Health professionals should be aware of the impact of stigmatizing attitudes. The title model promotes focus on patient strengths, which replaces biased attitudes. The DNP promotes policies and practices to educate mental health professionals and the community about mental health conditions, and using presentations and podium presentations, as well as social media to decrease negative stereotypes. Educating the nurse about mental illness and mental health issues and behavior embedded into every specialty. As an example, during the OBGYN rotation, postpartum depression should be discussed. Stigma experienced at several levels, how the public reacts towards a person with mental illness. Individuals with mental illness experience fear of being exposed to stigmatizing attitudes. They can also internalize negative beliefs. More research is needed to determine the cause and effect at each level. Nursing leaders should initiate and promote education at the clinical site about mental illness, beginning with orientation and yearly cultural competency trainings. Nursing leaders can also educate the community about mental illness to decrease society's negative perception of individuals with mental illness. Some of the limitations were the sample size of N32 when N105 was recommended. The CAMI tool was confusing, self-administered tool. The CAMI tool was created in 1981, contained outdated language, and some aspects had been scarcely addressed. For example, time needed for completion, difficulties in understanding the item, or the scale's acceptability has been explored. In the opinion of the team of researchers of this article, the next step should focus on items refined to create a uniform set of items, especially considering the influence of culture and context on the expression of stigma. And this was by Sanabria Mazo et al. 2023. Transferability. Other areas of medicine and nursing can benefit from studies about stigmatizing attitudes or negative stereotypes about mental illness. Along with mental illness is substance use that is associated with stigma being attached. Military members are afraid to seek treatment who suffer from substance use disorders. Other medical professionals should be studied to determine if they also have stigmatizing attitudes as staff working in emergency units and in other units in the hospital and other settings in the hospital. Quantitative data, participants who were advanced practice nurses with at least 20 years of experience were most frequently observed. Most of the participants had experienced peers talking derogatory about those with mental illness. Participants understood how DEI related to health disorders and had experienced coworkers with derogatory attitudes toward mental illness. Authoritarianism, social restrictiveness, which indicated less stigma in these subscales, also benevolence and community mental health ideology, these scores indicated had high scores indicating less stigmatizing attitudes. Participants had less stigmatizing attitudes towards those with mental illness, as showed in the CAMI results. Participants had less stigmatizing attitudes towards mental illness, as shown in the CAMI. The open-ended questions showed themes of negative stereotypes and historically negative attitudes towards those with mental illness from the community. These attitudes show lack of understanding of mental health illness and the need for education about mental illness. The PET stage of Johns Hopkins evidence-based practice model. P, the practice statement. In individuals working in mental health setting, what are their attitudes and self-perception of mental illness? Diversity, equity, and inclusion. Planning the implementation to educate all nursing staff and all health professionals about mental illness and the effects of stigma on individuals with mental illness. Evaluation, continue to evaluate the self-perceptions and attitudes of all health professionals. And T is translation of the outcomes into practice, working in the community through journal articles, podium presentations, and social media to decrease and eliminate the negative stereotypes attached to mental illness. Advanced practice nurses will have the opportunity to educate other professionals, the medical and larger community about stigma attached to mental illness. Although this project does not show those who specialize in treatment of mental health have stigmatizing attitude, it does show education is needed to decrease and eliminate stigma. Here's my references. Acknowledgements. Any questions?